Hello everyone. If you can all sort of sit down, that'd be really good. Including you, Jason. Okay, so we've got a session today which is entitled Hepatitis C, Elimination, Progress, Testing, Innovations and Advanced Liver Disease Management. And we've got some very interesting speakers. We're going to have a 20-minute presentation each. And then they're going to come up and sit up here, and we'll have questions at the end of the three presentations. And we also will be monitoring the chat, so do please send questions on that or note them down so you can ask at the end. Yeah. Okay, so we're going to start off with Jordan Felt, and I'm not going to read his whole biography, but he's a trained hepatologist at Toronto, and he leads a large clinical translational research program on viral hepatitis. Thank you,
Perfect.
Jordan.
Thanks, Peter, and thanks to the organizers for the kind invitation. And I'm going to be talking about innovations in Hep C testing, practical implications for enhancing cure. And although a lot of in a sense, we know a lot about the testing modalities, what's nice is in the very recent past, we've started to generate some data to support actually using this in care, and I'm going to try to highlight some of that. So here are my disclosures. I do research and some consulting, mostly in Hep B and Hep C. And so what I'll first do is describe what the tools are, our laboratory and point of care options, and then the various strategies about how to use these tools in various settings, and then really spend the last bit of time talking about how to match the tool to the strategy, thinking about the different settings and the population where testing is being done. And we're all sort of familiar with this concept that diagnosis clearly needs simplification, with people requiring to go to see a provider multiple times to get through antibody testing, get a result, get an RNA test, get a result, and only then can they start therapy. And the problem is that you lose people along this pathway, and we clearly have seen this happening for a long time. And when we look at the cascade, again, old data showing that the big drop-offs are early on of people not getting an RNA test after an antibody test, and then getting people to that first appointment to initiate treatment. And these are really repeatedly the biggest problems. So what we'd prefer to see is a very simple strategy where ideally we avoid taking blood at all, aside from, or at least phlebotomy, so a finger prick. You've got some type of point of care diagnosis of ideally viremia. You exclude cirrhosis with a very simple tool, either transient elastography or possibly blood tests, and then you get someone started on treatment. And you do this very quickly, and this is be particularly important in certain populations. So the tools we have available, there's a number of laboratory-based assays. We're very familiar with Hep C antibody and HCV RNA testing, and I'll talk a little bit about Hep C core antigen testing. And then on the point of care assay side, we've got antibody and more recently HCV RNA testing. We can collect these either in serum, whole blood, dried blood spots, or for antibody in saliva. And there are pros and cons to each of these. So the advantage on the lab side is that it's high throughput, relatively low cost per test, and it's highly automated. But the biggest problem is that there's the issue of time to result. It's got to get to the lab, and you can lose people in that process. On the point of care side, it's relatively rapid, and so you have reduced loss to follow-up. The cost can be an issue. It's generally more than lab-based assays, at least at a cost per test. It has relatively low throughput, and at least for HCV RNA point of care testing, the operators need a little more training, so this can be at least a little bit of an issue. So let's talk briefly about core antigen testing, because this is a possibility for thinking about how you could diagnose viremic infection without HCV RNA. And so we can take a tool from COVID-19 where we were able to get COVID or SARS-CoV-2 antigen tests that were very rapid, 5 minutes, and they were very cheap. And this was cheap enough to really allow you to skip, and if you could do this, you could skip serology testing altogether. And so Hep C core antigen does correlate well with HCV RNA, but it's a little bit less sensitive. The sensitivity, you really can only pick it up when there's about 3,000 IU/mL of HCV RNA. The nice thing is it can be done, at least in theory, on the same sample as the antibody test, so a simple one sample can be sent, and it should be cheaper, although the actual cost of a test, of course, is usually not that related to the cost of goods, so it's a little bit arbitrary. It's fully automated, but it does require a central lab, which is problematic, and it's going to be difficult to make this a point-of-care tool because you've got to lyse the sample, dissociate the antibody from the core antigen, and then amplify the signal to get adequate sensitivity. And all of that is difficult from a basic science perspective. So it's not likely we're going to have a point-of-care core antigen test anytime soon. But it's relevant to consider it because it can be useful in certain settings, and there are a few different available assays, and they perform fairly similarly with very good specificity. The sensitivity is good, but the sensitivity, it drops off a little bit at the lower end of the viral load, and there may be some issues about doing it in the setting of co-infection. So does this low viral load issue matter? Well, we have data from a few years ago now that showed a large collection of samples, over 60,000 from around the world with different genotypes with HIV co-infection, and you can see that 97% of people had a viral load above 1,000 IU per ml. So with our current tests, if you look at this, if you sort of look at the threshold at which you would miss someone with the different tests. So if you look at core antigen, you can see 3,000 IU, you're gonna get 97% of people. With the real-time PCR at 12 IU or the gene expert at 40 IU, you're gonna pick up slightly higher percentages. And so this is relevant, and actually EASL now recommends that HCV RNA tests should have a sensitivity of going down to 1,000 IU per ml. But it's important to consider that when you look in this study about who actually had a low viral load, the people who were more likely to fall below that 1,000 IU threshold were people with genotype 3 infection, people with co-infection, and people with cirrhosis, all groups that we don't want to miss. So this is important when you think about using this as a tool for screening. So the sensitivity is good, but it's probably not good enough, and I would say yet, because although making it point of care may be tough, I think you could make a better core antigen assay with improved sensitivity, and particularly given this issue that the false negatives are in groups that we don't want to miss. It also performs a little less well for confirmation of SVR. You get both false positives and false negatives, and I mentioned that it's very unlikely to become a point of care test, at least with the current technology. So for now, as a sole test, the only real option would be to have a combined antigen and antibody test and test HCV RNA done in people who test antibody positive, core antigen negative to find out whether or not they're still viremic. So this would be helpful. It would reduce the amount of RNA testing, but it's really not an overall huge solution. That being said, an improved core antigen test with better sensitivity could be a major step forward, and if it could be made point of care, so it was very cheap, that would really be a big benefit. Now, so if we go on to the point of care side of this scale and look at point of care antibody assay, we've known for years now there's a number of different rapid diagnostic tests and really truly point of care antibody tests that can be done rapidly, either from whole blood serum or from saliva. And you can see that the sensitivity and specificity is very good, but with saliva it drops off a bit. And because of that, it is not approved in North America, in the US or Canada, but it is approved in many other parts of the world, including here in Europe. Now, when we think about HCV RNA, everyone's familiar with the gene expert, and this is a relatively easy to use rapid HCV RNA test. And the nice thing is that the platform is available in many low and middle income countries. It's got a broad diagnostic range. The downside of it is that it's sort of what I would describe as near point of care. It's still about an hour to result. You can speed that up a little bit, and I'll show you in a minute. It's got a very good correlation with standard PCR assays and very good real-world performance, but at least for now, it's still not approved in North America. So again, limiting its utility, at least in certain settings, but it's increasingly becoming available around the world. And there's some great data from Australia, which we'll talk about in a moment, showing that it can be really impactful. And Jason Grebley's group did some nice work to show that you could speed this up a little bit by looking at the time to positivity. So if someone's got a positive test, they will come up faster than if they've got a negative test. So you could get 80% of people could get a read in less than 40 minutes, and the overall time to get a positive test was a median of 32 minutes, so just over half an hour, which is pretty good. But to rule out an infection, you still had to wait almost an hour. So that's still a bit of a challenge for people to come in and to call something truly point of care. The other challenge is that throughput isn't very high. You can only load a small number of samples onto the cartridges. So could we do better? Well, I think we could learn from the experience with the pandemic. The point of care antigen testing could really, I think there is improved technology. This is going to be tougher to do from blood than from respiratory secretions, but I think we could use some of the technology that improves sensitivity to get antigen testing better. And I think it's possible to get true through point-of-care RNA testing. And I hope that we're going to be able to do this. And an important step was that the FDA recently downgraded HCV nucleic acid tests from a level 3 to a level 2, which lowers the cost for manufacturers to get an application for approval, and hopefully that will encourage manufacturers to get into this game and give us better tests sooner, because ideally we would have a test like we did for COVID where you could get a PCR test back in 15 minutes. And actually there's some interesting technology with CRISPR, not CRISPR-Cas9 for gene editing, but CRISPR-Cas12 or 13 for detection, where you can get a very rapid and a potentially very cheap PCR detection, which could be sensitive enough and possibly cheap enough to enable us to do initial RNA screening, and that's potentially quite exciting. But can we use our current tools better? Are there data to guide us? And this is what I was talking about at the beginning, where more recently we have some new data showing how to actually use these and giving us a bit more confidence about how these tools can be used. So first was this nice systematic review that we published in Clinical Infectious Diseases about the importance of reflex testing. And some people might say, well, this isn't so surprising. We know reflex testing is a good idea, but it was actually really important to put these data together to encourage labs to actually adopt this, because when we look around the world, we see it's not actually used as much as it should be. So what they did is they compared 3 strategies: the sort of standard non-reflexed, where you go antibody and then come back for another visit, or a laboratory reflex sample, where either the same sample or a separate sample is sent to the lab, or a dried blood spot is taken and sent to the lab after a positive antibody, and you do an immediate RNA, or a so-called clinic reflex, where you use a point-of-care antibody and that leads to a point-of-care RNA. And what they then looked at was whether or not that increased RNA testing after a positive antibody, whether it improved linkage to care, and whether it improved treatment initiation. And what you see here is that the big effect of reflex RNA, which is no surprise, is that it improved RNA testing. So obviously if you're reflexing it, almost everybody's getting an RNA, and you can see that that's happening much more frequently with either of the reflex strategies in the clinic or the lab. When you look at linkage to care, smaller effect, but there does seem to be at least some effect, or a trend to an effect, on the terms of initiating treatment. And to be honest, these data don't look that impressive, but I think part of it is that the studies haven't been as rigorously done as they should be. So what you clearly learn from this is that it enables RNA testing. There's some suggestive benefits downstream in the cascade, that you get linkage and treatment initiation, and the effect is likely greater with clinic-based reflex testing, which kind of makes sense, because this is, first of all, you need to have a point-of-care antibody test to do that, but that's the only thing that's going to allow you to have a same-day start. And this is now recommended by the WHO, but I would argue that it would be helpful to have more data to show the benefits downstream in the cascade to update this meta-analysis, particularly from low and middle income countries where this could be extremely impactful. And although that's true, I would still say even with the data we have, this should be universally available in every country in the world. Central labs should be reflexing RNA 100% of the time, and that is not currently being done. Now, what about our point-of-care antibody tests? Can we make them faster? So this is a study we did a couple of years ago using the OraQuick point-of-care antibody test, and what we looked at was whether whether their antibody levels go down over time after they've cleared the infection, and we found that people who are viremic test positive much faster. So the label tells you have to read the assay at 20 minutes, between 20 and 40 minutes, and we found that everyone that's got a viremic infection has enough antibody there that they're positive by 5 minutes, whereas you can see that people who are not viremic, there's a range. Now, so it's important to interpret these data correctly, that if it's negative, it means that they're not viremic, and this is helpful because it reduces the number of RNA tests you need to do. It also, you don't have to make people wait around for 20 minutes to get a result, which at least in our experience in some populations can be really impactful. We found among people who inject drugs, we lost about 18% of people waiting for 20 minutes, and we lost less than 1% waiting for 5 minutes. But importantly, a positive test within 5 minutes does not mean they're viremic, so you can't use it the other way around. It just excludes viremia, and this was recently validated by a group at UPenn showing similar data, very good at 5 minutes. They found that it was better at 7 minutes, but the people where it didn't work between 5 and 7 were all either immunosuppressed or possibly had acute infection, and of course this rule won't work in acute infection where people might be antibody negative. But I would highlight that these tests are still slow, because when you look in the HIV world, point-of-care tests come up in 2 minutes. So, and the INSTI test for Hep C antibody is also very fast and will hopefully be available more broadly, but I think we could do better with our point-of-care antibody tests. Now, what about using point-of-care antibody tests and RNA testing in a clinical setting? And this is, again, from Jason's group, a really nice study done in the prison where they compared people sort of with a control, which wasn't bad, to be honest. The control, the standard of care was pretty good and better than in most prisons. But then they looked at what they called their one-stop, one-shop, where people got a point-of-care HCV RNA, point-of-care surface antigen, a fiber scan, and had an immediate assessment by a nurse. And what you see is that their median time to HCV RNA, of course, they were doing it immediately, so it went from 47 days down to 0 days by doing this immediately. But importantly, the median time of HCV diagnosis to getting a prescription for treatment went down from 5 days to 1 day, and the median time to treatment start from 25 to 6 days. But more importantly, 93% compared to 22% in the control arm actually received treatment within 12 weeks of entry into the prison. So this leads to a rapid workup, and I think this is really exciting data to see, and it's important because these are the kind of randomized data which actually lead policymakers to say we should invest in this. The program for the National Point of Care program in Australia has really seen remarkable uptake now with over 15,000 tests, Jason recently told me. Amazing uptake, particularly in the prison setting, and this is really inspiring to see. Now, we can also see what is the impact of point-of-care RNA on treatment uptake and timing. And here again, a nice meta-analysis recently published this year of 45 studies looking predominantly at people who inject drugs, people struggling with homelessness or with a history of incarceration. And they compared this to different settings. So it was either point-of-care RNA in a clinic, in a mobile setting, or in the laboratory versus centralized RNA testing. And so, as you might expect, they did see that point-of-care testing improved treatment uptake. And so you can see 77 or 81% compared to 53% in the standard of care arm. The median time to treatment went down, and the benefit, importantly, for testing was greatest in people who inject drugs and people struggling with homelessness, whereas the effect on treatment was greatest in the prison setting. And really, the effects were clearly greatest. They looked in different models and with a simplified care model, so the point-of-care test on site, and ideally with treatment also delivered at the same site. So bringing everything together, sort of like the one-stop, one-shop that was done in the PIVOT trial. Now, the challenge here is they had limited direct comparator data, so it made it difficult to really get clear evidence for the benefits here. And so I would say we really do need high-quality RCTs in this setting. Sometimes these are like proving the obvious, but it's really important because that's how we get buy-in to try to do these. And again, the Australian National Program should help. In some settings, you might actually consider going to point-of-care HCV RNA right away. And so we and a group in Melbourne have evaluated this in the setting of a supervised consumption site where we evaluated people coming into the site and tested them for HCV RNA, and we found a very high prevalence, not surprisingly. Now, in our experience, we were able to link just over half of those people to care, partially because of restrictions that we had in our province around how quickly we could treat people, which was frustrating and have since been largely lifted. Whereas in Melbourne, where they have very good access, they were able to treat people right away, and you can see that almost 90% of the people they tested were treated. So does this make sense? Well, again, we can turn to Jason to get the answer here. So we've got some good data on when should you actually start with an HCV RNA and skip antibody altogether. And so some people might have thought that prevalence, I think most people would have said 30, 40%, you should probably think about HCV RNA testing right off the bat. But what they showed in their study, and this was a modeling study in different settings, that point-of-care testing, antibody and RNA, first of all, is more cost-effective than standard of care. And the reason for that is that it enables treatment uptake. So that's really important. It's more cost-effective, even though the test costs more. But point-of-care antibody followed by point-of-care RNA is the most cost-effective unless the antibody prevalence gets above 74%, so really high. It's a little bit improved further if you ask people if they have a history of Hep C or Hep C treatment, and the cost effectiveness, again, is due to the increase in treatment uptake. And It's important to consider this because there are some although practical advantages to doing antibody testing first. It's more cost-effective in most settings. It gets faster turnaround time, which allows higher throughput, and it's really the preferred option in most settings, also for providers. What about self-testing? So this was initially recommended based on experience from HIV, actually with no evidence in Hep C, but FIND has done some nice pilot studies looking at self-testing using the OraSure saliva test in a number of different countries. You can see them there in different populations. And what you see is that there's very high acceptability. What that graph shows is that most people found this to be easy or very easy to do. But there were some errors with collection. There were some misinterpretation of results. There was generally good agreement with provider-administered tests, over 90%, but not perfect. And importantly, it was a little more costly, but it still proved cost-effective because it led to higher treatment uptake. And so I think this is good to see in emerging data on self-testing. Another nice self-testing study done out of Pakistan, led by Saeed Hamid. And what he showed here is in a pretty large study here, you see now 1,000 people doing self-testing, and in a control group of 224, only 7% went on to get went on to get testing after being asked to participate. So you can see that they did have a high rate of uptake, which was great. But interestingly, the two things that were notable here are that the viremia rate was much lower in the self-tested group. And I think at least raises a question about whether there might have been false positives using this strategy, because these people were reporting their own result, or whether it's a different population and that's actually getting the test done. And I think it'll be interesting to see this, but it's certainly promising data. So then the final point is trying to match the test to the setting. So thinking about the test type, the collection method, and then matching that to the setting and to the location or provider type. And so when we think about this, I would just mention the point that don't let perfect get in the way of very, very good here. This is important because when we consider the populations, the sample type, the urgency of treatment, there's always going to be differences here, and you can think about different strategies, but I would say it was done pretty well for COVID-19, where people sort of figured out where to use a rapid diagnostic test versus PCR, and we're going to need to think about this and get it right to really enable cost-effective elimination. So just to put some examples to this, our current model of the standard of care is kind of okay for things like baby boomer screening, but not really very good in other settings. Point-of-care antibody followed by either point-of-care RNA or dried blood spot testing is great when you have like screening drives in prison, OAT settings, prenatal testing in the emergency room. Point-of-care saliva may still have value in places where you don't want bloods or sharps or time is an issue. I think this is another consideration. And going straight to point-of-care RNA is really only going to be useful with very high prevalence. It's important to consider dried blood spot testing, particularly in rural and remote settings where you may not have access to a lab, hard to reach populations, or peer or self-collection where this could be quite useful. We definitely do need better point-of-care and RNA tests. Many settings, they're not approved, or they're approved, but they're not covered, the cost, and that's really a problem. I think we need to make our rapid tests more rapid. There is better technology, and we need to access it. We need approval of all of the collection methods, particularly dried blood spot, which is not approved on most assays. And it would be nice to have point-of-care tests for ALT and AST and CBC to allow for APRI or FIB4 fibrosis assessment on a point-of-care test. So to summarize, standard Hep C testing and diagnosis is really not ideal. Improved tests do exist, but they're underused. There are solid data now for the benefits of point-of-care antibody and point-of-care RNA, and despite their higher cost, and this is really key, they're more cost-effective because they lead to increased treatment uptake, and in most settings, point-of-care antibody should precede RNA. Core antigen may be useful, but until it's point-of-care, its utility is less clear, and self-testing, I think, looks promising. But we really need to expand what we have, but we shouldn't be complacent here. There are better tools. There are better tools that could be made, and they could make a huge difference to elimination efforts, and we need to advocate for that and push hard to bring that technology to enable elimination. And with that, I'll finish just over time. Sorry.
Thank you, Jordan. Thank you. And if anybody's got any questions, we're going to do some questions after the next two speakers. If you're using the app on your phone and you're in the meeting, then you'll see there's a question box. Please put your questions in there and we'll pick them up here. But now it gives me a great pleasure to introduce Dr. Fumi Lessie. So Fumi is currently the Viral Hepatitis Team Lead Global Hepatitis Programme. This is a really long, Department of Global HIV, Hepatitis and STI Programmes. And you're at WHO headquarters in Geneva, where you coordinate and support the three-level implementation of the Global Hepatitis B and C Elimination Strategy for Country-Level Impact. And Fumi's going to be presenting monitoring and measuring progress towards Hep C elimination.
Thank you very much for the excellent introduction. And I'm trying to catch my breath back from Jordan. The speed at which he spoke left me gasping. So I will not try to speak even half as fast as he does. So pardon my slow English, if you will. So really, can we measure hepatitis C elimination? I mean, it sounds really out of reach. But in the past week or two, we saw it happen. We saw Egypt being certified on the path to elimination. So obviously, it can be done, and we need to monitor and measure progress towards this elimination. So the outline of my talk, I have 5 major points to make. We look at the impact and program targets using the WHO Global Framework. We look at the approaches and feasibility of monitoring and measuring. And it's interesting that we have done in-depth review in 7 countries to sort of see how these approaches are practicalized. We now defined a tiered approach to elimination, and then I'll highlight some take-home messages. So, of course, we know that people who inject drugs are a very important group in the HCV epidemic, with 6.1 million infections. They have the fastest growing route of new infections, and there are specific WHO elimination incident targets and program targets for hepatitis C. So the WHO Global Health Sector Strategy outlines the need to generate and use data to drive precision for action, and obviously there needs to be a mechanism to monitor the progress of this elimination. So countries obviously need robust information systems that address all of the strategic information needs, of course including collecting, managing, analyzing the data, and of course building better country data systems and aligning the data sources, and even more recently, looking at various estimates, including data triangulation and modeling using empirical country data. So this is a reporting system that was developed at the onset of the hepatitis response regarding hepatitis B and C, and looking for data. What are the data needs for hepatitis? It's a program that brings together different vertical programs, including hepatitis B vaccination, the B programs, the C, the harm reduction, and as you would see from this slide, many of these already have pre-existing reporting formats. For example, harm reduction is reported in the WHO UNAIDS Global AIDS Monitoring System. What was lacking in a reporting system are the cascade of care and the impact monitoring. So this is the global framework that was developed for country validation of hepatitis B and C as a public health problem, which I know many of us know. It was developed first in 2021 and updated in 2023. One of the most significant differences in this framework, first we know it highlights the elimination targets for both hepatitis B and hepatitis C. And I've identified 3 boxes shown on the screen that maybe we'll dig into a little bit deeper. One of them is the annual incidence of hepatitis C, and this is, the threshold is less than 5 per 100,000 population. This is previously known as 80% reduction. So the 2021 guidance converted all the relative targets to absolute targets for very good reasons. For people who inject drugs, the absolute target that corresponds with 80% reduction is less than 2 per 100,000. Now, the combined mortality for hepatitis B and C is one of the new additions in the 2023 edition of this document. The testing and treatment, the prevention is about 300 needles per syringes per peewit per year. And of course, we know that countries have various options for validation. And in this case, highlighted is Hep C, which was undertaken in Egypt. Now, talking about the global progress, how do we measure HCV incidence? How do we measure mortalities? And I've briefly summarized here for measurements of incidence. We're looking at various prospective, retrospective studies, and modeled estimates. And similarly, for mortality, we're looking at direct data from vital registrations and sequela surveillance, as well as modeled estimates. In terms of program targets, I think we all know the program targets very well. One of the things the updated version did was to really standardize the definition of indicators as seen in the column on the right. So one of the prior studies done before the 2021 guidelines was to look at 28 countries and assess their readiness for elimination, to look at their data systems to see whether they were fit for purpose to monitor the elimination targets. And what we did in 2021 to 2022 is we actually did some country pilots in 6 countries in all the WHO regions and included UK. And we included UK because of their advanced data system and the possibility of exploring modeling and empirical data. The pilot countries are noted on the screen, and the objectives of the study is also noted to pilot these criteria, to evaluate the capacities in the countries to promote readiness, and to get some feedback. Tools were developed, pre-assessment tools, and we had sequential desk reviews in each of the 7 countries with over 30 meetings with ministries of health in 7 countries, 14 workshops conducted, and we had partners involved as well. So the findings were quite interesting, and of course, we know that UK has done quite a bit in terms of viral hepatitis, and what we see in the red, or we see in terms of HCV incidence, for both general population and key population, UK had complementary data. They were not using the WHO recommended methodology at that time. We look at the prevention, testing, and treatment programs, and we note that 40.4% of the people with chronic HCV has been diagnosed and 65% treated. Of course, that is short of the 90% and the 80%. We also look at the needle and syringe distributed per person who injects drugs, and we see that, again, this is complementary data. In terms of opioid agonist in dependent people, this was 73%. So the table on the right simply shows the estimated UK-wide proportion of peewit testing positive for HCV who were aware of their infections between the year 2011 and 2012. Now, this is interesting. I know it might be difficult to see, but the country pilots from Egypt, Georgia, Thailand, Rwanda, and Mongolia are shown here. In terms of HCV infections incidents in the adult population, only 1 country had done retesting of people who were initially tested negative, which is the required methodology for identifying incidents. In countries like Georgia, they had done this retesting in key populations, so they had an estimate of new infections in that population. We'll quickly look at mortality as well. We had a lot of challenges with mortality reduction simply because of the natural history of the disease to liver cancer that makes mortality estimations difficult, except in some countries that do not have an epidemic in the first place and have a low entry point. So in terms of syringes distributed per PWID per year and the OAT in people who inject drugs, many countries had no estimates, or countries had complementary data, so every country is measuring in a different way. So the country level results are shown here. So just to highlight some of the lessons learned from this pilot, the general population sero-survey was present in 3 countries. The absolute HCV incident threshold remained difficult to attain on a population level due to many reasons. For a country like Egypt, is the large baseline burden of HCV that requires resources and political commitment. In other countries, it's just the difficulties of measuring incidence or estimating mortality. All countries were able to measure the program targets, but in all countries, even in the UK, measuring progress in NSP remained challenges. And of course, the plans for IBBS survey was quite welcome to estimate the baseline and burden of key populations. The importance of person-centered data monitoring was highlighted. Now, these are challenges, I'm sure you know this already, but 4 of the 7 countries were able to show NSP coverage at a population level. Now, countries highlighted the role of criminalization of making these challenges. Now, the absence of a program response or systematic data availability in this population was noted in most LMIC countries. In some countries, the government did not even consider that PWID is a public health priority. It was difficult to measure NSP coverage, and it was clear that even testing and treatment without implementing harm reduction strategies will not take us to elimination. So both testing and treatment and risk reduction must be pursued. So what are the implications of our findings? I think the main one was to establish a criteria for what we now call path to elimination, and standardized definition of indicators and refined tool. Now, the rationale for path to elimination is clear. Measuring absolute incidence, less than 5 per 100,000 or less than 2 per 100 PWID, is a challenge. Measuring incidence and mortality is also a challenge. And we do know that modeling has demonstrated that the synergies of the interventions for hepatitis B and C can lead to elimination. So we have to develop a metric that does not require measurement of impact targets as part of this approach called path to elimination, which I now show on the screen, and that was developed in 2023 April in a global consultation with 40 to 50 stakeholders from different parts of the world and ministries of health. So this is a stepwise progression from bronze to silver and gold tier, which are aligned with the programmatic targets, including harm reduction. And the idea is that this standardized approach to monitor progress will enable countries to build and strengthen their systems. Of course, it requires national planning because elimination does not occur in a province or in a state. We need data from an entire country to demonstrate elimination. Sustained implementation of interventions for prevention and care. And of course, regional and global recognition via the process of validation. So what is shown here is the bronze tier, the silver, and the gold, with every step and every tier demonstrating an increasing level of service coverage to the ultimate elimination. I'll show here a little bit about harm reduction, and the harm reduction targets where it took a lot of discussion and deliberation to reach these harm reduction targets, and the bronze target on the path to elimination requires a government-funded NSP to be present in the country. This was not present in many countries. In many LMICs, they were partner-supported or pilot projects, and the silver criteria requires NSP and OAT to be present in the country at a national level owned by the national program, while the gold was about 150 NSPs per year, but the full validation still requires the 300 NSPs per year. So Improving global and country viral hepatitis data is key. WHO launched the first global reporting for viral hepatitis to track progress on a few areas, including the burden, cascade, surveillance, and policy implementation. You would see on the graph on the right that in the first year of this global reporting, 68 countries reported data. Now, intensified partner collaboration and agreement for a data collaborative to align the global estimates have really buffered up this number. In 2018, 130 countries, in 2021, 130 countries reported, strengthening the importance of partner collaboration. Currently, the 2023 global reporting is ongoing. The reports are expected to be out by the end of the year. And this global reporting is for ministries of health of countries to report all of these important fields. They are aligned with regional specific data systems translated in various languages and it will receive both online and paper-based reporting, which is also one of the challenges in low-income countries. Now, some of the major outcomes of the data collaborative include the establishment of global estimates and aligning hepatitis B and C burden estimates, and also a modeling reference group, recognizing the increasing role of modeling for incidence, for mortality, and as an add-on to empirical country data. Country surveillance capacity is important because without the countries being able to report their data, it becomes impossible to collate data from every part of the country for national reporting. So now we have a stepwise recommendation for strengthening country surveillance. At the end of the day, validation or elimination is not in a county, it's not in a province, it's got to be the whole country. Currently, we're in discussion with the UK because the pilot was done in England, yet there are other nations in the UK, so UK has to come as a country for validation. Therefore, we need data from all parts of a country. In terms of strengthening country surveillance, the use of available data is important, and Ministry of Health needs to validate this data, highlight the gaps and the inconsistencies, and use their data for planning these services. Strengthening burden and cascade data, using the data to develop plans and identify the hotspots and the priority areas in their countries. And of course, an investment case is important. You need data to evaluate and cost your response. Again, strengthening person-centered routine data, and WHO is supporting countries to roll out DHIS2 to use data from hospitals. And of course, the outcomes analysis for liver cancer estimation for long-term mortality. So the cancer registry has been supported, the attributable fraction is being supported. And the key takeaways are, the first is the use of global reporting system to facilitate standardization of hepatitis data. The measurement of impact and program data are feasible and acceptable by member states. I think it's important to know that this path to elimination represents a tiered milestone of progress to elimination, and it prioritizes coverage of program targets without the need to demonstrate incidence or mortality till the full validation is applied for. It serves as a tool to promote national advocacy. It is developing programs, and that is evident in the story of Egypt and their key population increase to facilitate path to elimination. So establishment of this data collaborative will align global estimates and support country strengthening for reporting. And thank you very much for listening and for your time.
Thank you, Fumi. Very interesting. And now we have Mark Sonderop doing the last presentation, entitled Prevention and Management of Advanced Liver Disease. Mark is from the University of Cape Town, trained in hepatology, and he's currently a professor at the Department of Medicine and Hepatology. And research interests include viral hepatitis, HIV, and drug-induced liver injuries and liver disease. Thank you.
Peter, thanks very much. Good afternoon, everybody. And to Insu, thank you very much for the kind invitation. So I'm just going to say that I have a disclaimer, is that I work in a mostly resource-constrained environment, and my focus is thus from that perspective. The topic I've been given is huge, so for me, I may just be Jordan in the speaking Olympics today, but I'll briefly focus on a couple of key issues, and hopefully there will be something for everyone. So the global burden of disease, the big four: Hep B, about 258 million, Hep C, 58 million, alcohol-associated liver disease, which I'm going to touch on shortly, and then the rising specter of steatotic liver disease make up the big four. Just to remind everybody that, of course, these are not in isolation. There's overlap between many people. Some people have got steatotic liver disease and Hep C or Hep B. I think it's remiss of me not to mention the specter of Delta virus co-infection, and this meta-analysis from Alex Stockdale suggests about 4.5% of people globally are Delta virus co-infected with B virus. Just a bit back to alcohol. So COVID-19, amongst its many issues it's had on the planet, has certainly raised the specter of alcohol-associated liver disease, and this work was a survey done, published in JAMA, of just over 1,500 adults surveyed before and after, about 6 months into the pandemic. Median age about 57 years. There was a definition for heavy drinking. Overall alcohol consumption increased by 14%. People, at least 3/4, drank at least one or more extra days a month. And in women in particular, there was a 41% increase in the number of heavy drinking days. Unsurprisingly, the number of, in fact, in terms of alcohol sales, you can see a sharp rise at the start of the pandemic. And this has impacted globally, and this is really US data showing the increase in listing for alcohol-associated hepatitis and alcohol-associated liver disease for transplantation. So let's just talk about a patient, and let's use that as the basis on which I'm going to make a few pertinent points. So a 53-year-old man, he's an ex-PWD, presents with fatigue, sees his GP, and in fact does use alcohol 1 to 2 drinks a day. And GP does a number of blood tests. This is not surprising to anyone in the room. And you can see their platelet count of 82, well-preserved synthetic function, the INR just under 1, good-going hepatitis, and he is C virus antibody positive. Ultrasound suggests coarse echogenicity of the liver, portal veins a bit chunky, and the spleen's a bit chunky as well. Clinically, it's got the classic finding of you feeling the liver in the epigastrium, suggesting that enlarged caudate lobe, bit of a tippable spleen, and he's genotype 1A infected with evidence of previous cleared Hep B exposure. So cirrhosis, we know, is the final common pathway for most chronic liver disease. It's characterized, it's a histological definition ultimately. It's regenerative nodules surrounded by fibrous tissue, and once you have cirrhosis, your risk of progression and then ultimately to decompensation or the complications of portal hypertension or, of course, the dreaded HCC start rising. The problem with chronic liver disease, of course, is that it's silent in many people, and there may be clues that thrombocytopenia may be missed, that normal liver profile in many, but where the AST is a bit higher than the ALT, and of course sometimes the etiology is not particularly obvious. And we know that chronic liver disease exists in these two states, and they've got vastly different outcomes. And compensated chronic liver disease or compensated cirrhosis, in fact, has got a very good prognosis. But once you develop what's called clinically significant portal hypertension, which is really defined as a portal vein pressure, a hepatic venous wedge pressure of greater than 10 millimeters mercury, your risks of decompensation rise, and that alters your prognosis quite dramatically. And once you decompensate with variceal bleeds, ascites, encephalopathy, etc., of course, things look very different. And as I've indicated, survival outcomes are very different. This data is well known to many, seeing the long-term survival in those with compensation versus decompensation. Remember, we use a variety of classification for fibrosis. Probably the most widely used and translatable into certainly the non-invasive area is the Medivir system, ranging from F0 to F4, F4 of course being cirrhosis. So, where do we start? Well, the first point, as I said, it's a silent problem. So you have to actually diagnose the patient who's got advanced chronic liver disease, and that's making the diagnosis. And that's what I sort of say is my little summary for dummies because it kind of makes it really obvious. So there's nothing like good history in clinical examination. And down the left side of that pathway, obviously there's variceal hemorrhages or ascites or hepatic encephalopathy. I don't think you need to be a hepatologist to diagnose cirrhosis. And certainly if the platelet count is low, then that's the clincher to the diagnosis. Down the right pathway, if it's not that obvious, but there's suspicion, we need to actually diagnose the fibrosis. And yeah, we've really got a variety of ways of doing it non-invasively. And ultimately, liver biopsy is available and can be used, but of course, it is an invasive test. So we've got invasive versus non-invasive approach. And as I said, I'm not going to talk about liver biopsy because it's not something that's widely used. So let's spend some time looking at what we can do with the patient in front of us to give us the clues or clinch whether they actually, in fact, have advanced chronic liver disease. So we've got serum biomarkers and we've got imaging. Serum biomarkers, we've got a whole lot of essentially commercial tests available. And then we've got two really great tests we can use that it's simple, the APRI test, or the FIB4. Let's look at those a bit closely. We know that FIB4, APRI, and for example, if and with respect to, for example, steatotic liver disease, the NAFLD fibrosis score can be used. These have all got pretty good negative predictor value for ruling out fibrosis, and they're easy, they're cheap, they're available, they're on your desktop or on your cell phone. FIB4 actually performs very well when it comes to MAFLD. It's good for ruling in, ruling out. Remember, all these non-invasive tests have got these cutoff values for rule in, rule out, and this needs just to be looked at with essentially whatever application you're using. And I looked at this last year, and this was from Quinton Anstey. I haven't seen it in publication yet, but it was a poster at ASLD. It's a busy slide, but essentially what they were saying is they looked over a 20-year period in patients in UK at community level with fatty liver disease and a variety of other causes, and they looked at patients who had essentially had 2 FIB4 readings showing the long-term predictor value of FIB4. And everybody who was included had a FIB4 at least a year apart, and it showed that FIB4 in fact performed very well over time, predicting for those who had increasing mortality. So FIB4 really does pretty well at community level. I think it would be remiss of me not to mention that with all these non-invasive tests, the one issue we do have is, of course, they need to be validated in your own population. This is some work from a group I'm part of called HepsiNet, and really looking at a cohort of patients and trying to validate APRI scores for patients with chronic hepatitis B in Africa. And in fact, this has been published to suggest that cutoff values for rule in, rule out fibrosis are considerably lower than what we ordinarily suggested. And I'm pleased to say that I think a lot of this work has been included in the upcoming new revised guidelines from the WHO. So, biomarkers aside, what are we left with? We're left with imaging. What do you have available? I think it really comes down to fibroscanning, or it comes down to MRI and various other techniques, MRI being very costly, of course. What about fibroscan? We all know fibroscan's done. There's standardization charts. You're deciding what's rule in, rule out for advanced fibrosis. This is a busy slide, but what I want to show, and this was all based in fatty liver disease, published very recently, looking at a meta-analysis, looking at how these non-invasive tests actually perform in patients with steatotic liver disease, looking from your top clockwise from the left around. If you just look at the various levels of fibrosis and the actual performance in predicting mortality for F1 through F4, top left is for liver biopsy, then fibroscanning, then NAFLD fibrosis score, and then ultimately FIB4. I think one can see that, and the outcome of the meta-analysis suggests that these non-invasive markers in fact perform very well when compared to liver biopsy, and their dynamic sensitivity is very good. Putting this all together, if you have got access to fibroscanning, for example, how does it help you? Well, you put it all together and you include various criteria and suggestions, then in fact liver stiffness measurement can be very useful in actually risk stratifying a patient. And for example, looking at the Baveno criteria, if you're less than 20 kilopascal and your platelet count is more than 150, and you're in that range of advanced fibrosis, you don't necessarily have to refer that patient for endoscopy because their risk of having esophageal varices is actually quite low. And there's a good rule out completely for any advanced liver disease. And then above 20 kilopascal in fact, that's the patient who you need to pay extra special attention to. So shifting gear, so we've made the diagnosis. Patient actually has advanced chronic liver disease. What are you going to do? Well, the primary therapeutic objective in the patient is to prevent decompensation. And how do we do that? Well, it's very simple, treat the cause. So you've got to actually identify the etiology and treat the cause, and we know that treating the cause helps. This is data well known to everybody. The original data showing the benefits of SVR based mostly on patients receiving old interferon therapy, showing a reduction in HCC and mortality rates in those who achieve the SVR. And of course, from large Veterans Association cohorts showing this improvement in mortality and HCC reduction if you achieve SVR with DAA therapy. Just to remind one that, of course, making the diagnosis early is really important, because whilst there is an improvement with SVR, the more advanced liver disease you have by the time you actually get treated for your Hep C, for example, in fact, your outcome may not be as good as those with more compensated disease. What about hepatitis B? We know from Taiwan that the risks of progression relate to the presence of viral load. In fact, therefore, ergo treatment is needed with antiviral therapy. And this is a whole wad of data showing clear evidence that patients on long-term oral antiviral therapy have, in fact, even with established cirrhosis, on oral antiviral therapy with either entecavir, adefovir, tenofovir, improvement and fibrosis, if not cirrhosis regression. This is therefore unsurprising that patients on oral antiviral therapy for hepatitis B, even if decompensated and started on therapy, still have a better prognosis and a reduced likelihood of requiring transplantation. What about alcohol? Well, it may be really a stupid thing to say, but all treatment of alcohol-associated liver disease begins with abstaining from alcohol, and I'm actually amazed sometimes how this is not addressed, and people are not offered help. It's quite remarkable. In my own hospital, my registrars tell me about what are we going to do? We're going to use prednisone. What are we going to do? And I'm like, have you called the social worker and have you spoken to the patient about the alcohol use? Because that's what you need to be doing. And so this is data, and I thought I'll put it up intentionally. Look back at the original data. 1968, we've known for aeons that even if you got cirrhosis and you stop drinking, your prognosis improves. But yet, we're not very good at this. So abstinence truly does make the liver grow fonder. What about the benefit of actually intervening? This is again some VA data looking at actually intervening in patients with alcohol use disorder, either with behavioral therapy, pharmacotherapy, or both. Unsurprisingly, patients who are actually offered any therapy have a significant reduction in hepatic decompensation, all-cause mortality, and improvement in overall outcome. So clinically significant portal hypertension is the main driver of decompensation. What can we do in the patient? Are there little things we can do that make a difference? Well, the answer is yes. Firstly, in the Prudesky study, in patients, in fact, with these are patients with clinically significant portal hypertension. We included, in fact, were put onto beta blockade. They'd never decompensated before, showing clearly that beta blocker therapy, even in the patient who's never bled, in fact, improves outcome. And the probability of, in fact, experiencing a decompensating event declined. And importantly, the most important event that was reduced in this particular study was the onset of ascites. There was a little clue in the study that actually showed that carvedilol in this particular study may have been the more superior beta blocker to use. And I say that because we know patients with varices, it's all about size. Size matters with varices, and your risks increase, and your risks in bleeding increase with the size of the varices. And so you want to do something about it. And this data, I think, is very instructive. And this was really showing that patients using carvedilol versus propranolol, that carvedilol, in fact, performed better in terms of reducing the risk of variceal rebleeding and liver-related death. So I think we've reached a point where the beta blocker of choice is probably carvedilol rather than propranolol, but I think a cost issue still is at play here. Don't forget practical tips with beta blockers: titrate to heart rate, blood pressure, and start low and go slow. What about PPIs? mean, just ask anybody in the room who's on a PPI, I'm sure I'll see many hands go up. And we know that 20% of patients who bleed and have upper GI bleeds, in fact, are not varicose related, who in fact have cirrhosis. So we know that, for example, from this particular retrospective analysis, that PPIs decrease rebleeding rates after endoscopic therapy, but there's no impact on bleeding mortality. So if you're going to use PPIs, use it for about 10 days and discontinue it. And maybe this data, in fact, has suggested, and I think it's been shown again, that maybe sometimes PPIs, and particularly patients with advanced liver disease, Child-Pugh disease, is too much of a good thing, and their risks of SBP may actually be elevated. So stop the PPI if there's no clear indication in patients with advanced disease. What about the new kid on the block that's raising all the attention? What about statins? It just seems to be the gift, in fact, the gift that keeps on giving. In this first proof of concept study showing that, in fact, statins in the small group of patients reduced the hepatic venous wedge pressure in these patients, and this was shown back in 2009. We then saw ongoing data showing, in fact, that in this, in fact, was data from the Veterans Association in patients with hepatitis C-related compensated cirrhosis. Those on statins, in fact, had a better outcome, reduced risk of the development of decompensation. And you can see that decompensation indicated by the development of ascites and variceal hemorrhage. There was subsequent data that, in fact, suggested the same outcomes. So what if we add a statin to beta blockade? Well, there seems to be some benefit. It doesn't reduce rebleeding in those who, in fact, have a variceal bleed, but it certainly improves mortality. There was a problem here with some rhabdomyolysis in a small percentage of the patients, and so, yeah, dosing, of course, is important. I said it's the gift that keeps on giving. This is quite a few years ago showing that maybe statins reduce the risk of hepatocellular carcinoma in patients. This was in a patients with certainly likely steatotic liver disease, and more recently, in fact, showing the same thing in steatotic liver disease, that statins seem to reduce hepatocellular carcinoma risk. The commonest decompensating event in patients, if they're going to decompensate in all cirrhotics, remains ascites. And so if the patient is in front of you, what are a few practical tips? Well, avoid certain drugs. Remind them not to be using things like NSAIDs. Salt restriction is so incredibly important. And patients weighing themselves, just a scale, is really very useful to assess their fluid status. We know that, for example, if you start either a loop diuretic or an aldosterone antagonist together or sequentially, it doesn't really make a difference to overall response, but you certainly do mobilize ascites better if you do it conjointly, and in fact, the side effect rate is better if you do the diuretic therapy conjointly as well. Back to our patient. I said that we had this 53-year-old man, had hepatitis C, clear evidence of cirrhosis. We fibroscanned him. He had a KPA score of 28, and he had an endoscopy, did not have any significant varices. We treated him, he achieved an SVR, received advice and support to stop drinking. And so what do you do now? Do you pat him on his back and wish him well? No, you don't do that, because these patients are, of course, at risk of hepatocellular carcinoma. And HCC risk remains in these patients, irrespective. We know it rises with time. So what do you offer them? Well, you offer them screening, and screening is important, and screening is a talk all on its own. But the reality is that if you're going to do screening, probably what most are going to do is offer them 6-monthly AFP and ultrasound in terms of their overall HCC screening. And there are a whole new lot of essential biomarkers that have potentially come into play. One of them is the GALAD score. I'm not going to go into that now, but I think watch the space. It's an exciting area of development in terms of biomarkers to predict for HCC. So, a few take-home messages, and I'm amazed I actually have got in here in time. It's quite remarkable. So, a few take-home messages that remember that chronic liver disease is silent. Early diagnosis is absolutely crucial. Assess for fibrosis, and there's several options available. I've pointed to you that there's invasive, there's non-invasive, and I think non-invasive is probably going to be what most are probably going to use, and certainly elastography performs extraordinarily well, as I've showed you. Manage the cause. Prevention is always better than cure. I think there are several growing or now good evidence-based interventions that ameliorate liver disease progression. I think I've touched on statins and beta blockade. And I think there is much we can do with simple, cost-effective interventions to prevent the progression of advanced chronic liver disease. Thank you.
Thank you, Mark. That was sobering. I think really interesting, but I have to say sobering as well because it's the harsh reality of the impact. But yeah. So we have some questions. We've got hands going up all over the place. Amazing. Jason, do you want to go?
Sure. Fantastic presentations, everyone. I have two questions. My first one is for Funmi. So, by the way, fantastic work. I know how much work it's been to bring all this together. The one thing that you didn't mention that might be helpful for people working in various countries in the audience is what is the actual process by which, if a country now wants to be considered or validated, like what's the actual process for that? Is it that they just contact WHO? And so, but I'm serious in terms of a practical, how does a country approach the WHO to be considered to be validated? And I think that would be useful for people in the audience. And I'll wait until you answer that and I'll ask my other question to Jordan.
Right, thank you very much. There is a process, of course, and I think the first process is we have online tools for countries to assess where they are on the path to elimination or full elimination. So we have Excel tools for hepatitis B, for hepatitis C, for PMTCT, that looks at the infrastructure, the information system, their programs, and we also have a data collection tool so that countries can look at where they are and decide what they would wish to apply for. There is a governance process for validation, and it starts at national level, regional level, and global level. The first point of contact really will be the country contacting the WHO office in the country. That yes, we think we have met all the criteria, we think we may be at bronze, or we think we may be at gold, we have established a sentinel surveillance for gold, which is required for gold, or look, you know what, we are thinking that we are reaching the impact. So for that first step, already we have several countries communicating with WHO of their intention, and we are supporting them to evaluate where they are. The second step goes from the country office to the regional office with the same intention, with an official portfolio or dossier of the report. And like the process that Egypt has gone through, there is a regional validation committee, which is a bit independent of WHO. So this independent panel that comprises of experts from that region come together, evaluate the dossier from the country, and they go back in there to check a few things that the countries have said. One of the important things they look at is the laboratory infrastructure. They look at the programs and the progress. And one key thing they would like to see is the issue of equity and human rights. For example, in the recent validation, some of the regions had a treatment rate above 75, 85, 95%, while some other regions in that country has only 35%. So even though the average is above the threshold, we're interested that equity is being addressed. In this case, it was because there was some conflict in that part of the country, or people were quite mobile. After this regional level then goes to the global level, where we have a global validation secretariat, which also reviews the data from the regions and the country. So it's quite labor intensive, it's cost-intensive, and after validation or review by the Global Secretariat, then it's gone to the DG for signing, and they advise the DG of WHO that yes, this country has fulfilled all the criteria for validation or elimination in this case, and this is awarded to them. It's a huge advocacy tool, actually. And the path to elimination really promotes program development, and this has been quite well received by many of the countries.
No, it's been fantastic. But I think from a practical perspective, it's almost like a group of academics plus clinicians, like the stakeholders, community. So the practical is almost that a group of people within the country need to get together when they think that they're ready, and then they need to actually lobby the health department at the federal level to then approach WHO. Is that correct?
You know, I'll probably put it the other way around. I don't think it's the group of people that lobby. I think it's the government that needs to be committed and get the people together.
Yeah, it's which
Of
comes,
course.
the chicken or the egg sometimes, because you have to lobby the government to be interested to go.
So the people that are lobbying probably will be on the national validation or something, or the national programs, and they can identify that this entire country is well served by hepatitis resources. So whether it's chicken or the egg has to be done.
Great. Maybe I'll let someone else ask a question and come back to me
I was
later.
just about to say that. So, person over there?
I'm really happy to hear that there's an equity lens to the validation piece. I think we also want to be thinking about equity within population groups as well, because I think a lot of us can see that 20% left at the end being the most marginalised people in communities. I'm really curious to know what happens after a country gets their validation status. Is there a framework for continuing to eliminate or uneliminating?
I'm amazed that there's so much interest in elimination. But you're right, and I must say that this is the first ever hepatitis C or B elimination that has been conducted. So I take my examples from hepatitis B, PMTCT, or triple elimination. To date, there has been 16 countries that have been validated for triple elimination. So first, let me address the equity. For equity at the national, regional, and global level, there must be a person living with the condition as part of the panel. That one person or two people living with the condition represent their interest groups. So that is really very important. For example, for Egypt now, we have a set of recommendations on how they would improve their programs and close the gaps because they're not there yet. So there's a maintenance of validation that comes every 3 years. And just to mention something, some countries go from bronze to full validation. So it's not really, you do not have to go through bronze, silver, or gold. Some countries come in at silver, like Botswana, and their next step is to go to gold. So the whole idea is identify that threshold, map the gaps, and work towards filling the gap to maintain the certification. That is something.
I'll just say that I think a lot of us in our head have this like end goal, but it's great to hear that the process that the WHO is implementing is actually more of like a continuous quality improvement framework.
And I forgot to mention human rights. Human rights is a big thing. And one of the recommendations is that the country has to look at their policies of criminalization or discrimination. We recognize that a single disease cannot change the laws of a country, but we need to see movements towards policy change or accessing. And I think one of the things we heard is that in countries where there's criminalization, one of the steps we have achieved in one of the validations is to make sure that in the health facilities, there is no discrimination and no criminalization. That was a big step. And some countries have actually changed their laws based on this validation.
Thank you. We've got a couple of questions online. So one for Jordan. So Evan, up in the audience, was wondering where you would see hepatitis C self-testing be most useful. If it's outside the clinic, do you just have to accept the possibility that positive cases aren't reported?
Yeah, I think it's a good question. I mean, I think we're learning about where self-testing is going to fit in. I think, my original sense of this would probably be that it wouldn't have super high uptake. I think there's going to be a lot of things to consider who's paying for the tests. So for example, with HIV self-testing, there's a lot of education and advocacy within the community, and people are regularly doing the testing. I don't know whether that will happen to the same degree among people at risk for hepatitis C. I'd like to believe that it will, but I don't know if it will. So I would hope that in certain settings it will, and I could also imagine in some countries, to Fumi's point about human rights and stigma, that you might have populations where self-testing is for people that really don't want to come to a clinic because they don't want the stigma that's associated with that. Now, whether self-testing will be available in those places is another question. And I think your point about whether or not those self-tests are going to be into the health record for surveillance goes even one step further, because point-of-care testing in many places, even when it's done by a provider, doesn't get into the public health record for surveillance. So I think there's actually even a bigger problem there, and I think it's actually something we really do need to address with point-of-care antibody and point-of-care RNA testing. My suspicion is with self-testing, we'll probably never get it into the record, and at least for now, self-testing is always going to be antibody testing, so it's going to lead to an additional test, which will hopefully lead to engagement in care. And so I think that part of the downstream cascade will still be captured.
Thank you. Are there any more? Oh, there's another hand gone. We're going back. We're going back.
Sorry, if anyone else has a question, I'll wait. But so this is a question for both Mark and Jordan, and it's just about the approach to alcohol use in liver disease. And I hear from community really often that this all or nothing abstinence, or you don't get any help from me, is really quite harmful. And so I'm wondering, in the hepatology, gastroenterology community, is there any thought around a more harm reduction approach to alcohol use, where we can start to think about, reducing your alcohol use is a good thing? Because I think, there is a spectrum of alcohol use, and while our Canadian guidelines say that no level of alcohol is safe, I think there are levels that are safer. So yeah, just really wondering where the state of the field is with respect to that.
You can start. Yeah, I mean, it's a great question that doesn't have easy answers, because yet we have guidance for so-called safe alcohol drinking, but that's based on the premise and assumption that you have a normal liver. Okay, once you have coexisting or cofactors, that safe kind of falls away. And I think one needs to venture into the arena of sensible, and one needs to venture into the arena of, being practical. So if you have coexisting liver disease, and I mean, Jordan, I'm sure you ask this very often. A patient will sit in front of me and say, so, how much can I drink? Or, and this is sitting in liver clinic. So just, the actual context. And I always say to them, just before you ask me the question, just, remember who you're asking the question to and which clinic you're sitting in. So just, to contextualize your question. But the issue is that drinking less is never a bad thing. And if you can cut down, that's not bad. I think that's, that in fact is being practical. But I think then one has to, in fact, essentially delineate social drinking from alcohol use disorder, because I think that's different. Heavy social drinking, usually those folks have a little bit of an easier time actually seeing reality and cutting down. And, you can really just, in fact, provide them with some sensible advice. But alcohol use disorder needs an intervention. They actually need help. They actually need some sort of therapeutic intervention. I think that's different. And I don't know about other people's settings, but that's where I find things quite difficult. There's a lot of barrier to that, and a lot of barrier to actually help people in that area. So cutting down, yes, but I think importantly delineate those who've actually got AUD versus patterns of just significant social drinking. That's my
totally
simple take on this one.
Agree, Mark. And the only thing I would add is I think there's an increasing recognition among hepatologists particularly about sort of the harm reduction approach to alcohol use. whether it's alcohol use disorder or social drinking. And one of the components of that is actually prescribing anti-craving medicines. So when you look at the data on this, it is shocking how underused they are. They're actually reasonably effective, and they're incredibly underused. And certainly that's one of the things where I can speak for our own clinic and some of our own networks, that we've really been stressing a lot around education, around saying, we don't even necessarily need to send someone to addiction services. It's great if we can, but if we can't access those, we are quite capable of prescribing anti-craving medicines and continuing to follow people. And I think it's a little different than prescribing methadone and buprenorphine for opiate use disorder, because in the setting of Hep C, for example, if someone doesn't have advanced liver disease, they may not need to see a hepatologist after they're cured of their hepatitis C infection. With alcohol use and significant liver disease, they've got to continue seeing us, even if even if they maintained abstinence. So I think we have an important role for getting involved in that. And to be honest, I think it's an area where we need to increase it. The other thing that I sometimes talk to people about is, Mark showed it, the statistics are really horrendous for someone that actually ends up in hospital with alcohol-related hepatitis, acute alcoholic hepatitis and alcoholic cirrhosis. I mean, he showed that abstinence works, but I don't know if you saw those data. The numbers are shocking about how many people die from alcohol-related liver disease, and unfortunately the pandemic has made this so much worse. I mean, it honestly is the worst part of my job. We are seeing really young people coming into hospital with devastatingly awful alcohol-related liver disease, and all the drugs we can think about don't do anything compared to long-term abstinence. So we need to figure out how to do that better.
Can I just throw that in? And a couple of hands have gone up. Just quickly, though, to say that there is not enough publication communication around this, because people have no idea. That's what I'm saying. It's quite sobering, Mark, your presentation, because actually I think there's a lack of information, a lack of knowledge around the consequences of, and like you say, after COVID, huge, huge increase. Sorry, I don't know who went first. Did you? We put your hand up first, sorry.
Sure. So my question is for Jordan. You talk about the availability of so many sophisticated tests that can potentially simplify the treatment and improve linkage to care, but coming from LMICs, what we have is everything boils down to cost. And for example, GeneXpert is much more quick, and it shows that the linkage to care is better with GeneXpert as compared to PCR. But the thing is, for mass testing, we cannot afford GeneXpert's cartridges, although we have the infrastructure there, but we cannot afford the kits. So you also talked about skipping antibody test altogether. So these new interventions are coming in, and in our country, for example, in Pakistan, we need these interventions. We need quicker tests, quicker viral load. We need quicker linkage to treatment. So what are your thoughts on that?
It's a really important question, and I tried to highlight it. I probably spoke too fast, but I think it is important to consider, to distinguish between cost and cost effectiveness when it comes to this, because there's no question that some of the rapid tests, whether it's a point of care antibody or a point of care RNA test, are more expensive than doing it in a centralized lab. But if you end up getting more people on treatment, and you end up getting more people cured of their infection, then the overall cost effectiveness is actually better. And I think that's actually really nicely shown in the paper that Jason's group put together in Lancet Regional Health, one of the Lancet journals. But they really highlight that point, that it is, although it's more expensive than standard of care antibody RNA testing, it's more cost effective to use the point of care tests, the antibody and the RNA test. And again, that the only time you're going to think about doing first time point of care test, RNA test, is when the prevalence is super high. So what they found in that study was 74% antibody prevalence. There's not many settings, even among people who inject drugs. Most settings don't have a prevalence above 60%, and most are actually 40% or lower. So it's going to be usually antibody first. And I think this is one of the things where you need data, and you need to sit down with your policymakers and show them and say, look, you can use a cheaper test, but at the end of the day, it's going to cost you more to get to elimination, because you're going to lose people to follow up. There's going to be more subsequent infections because those people aren't connected to care. And in the end, you end up paying more for your overall program than if you use a more efficient test that gets people into care.
So I just have a question linked to that, which comes from online. So I was just wondering what you think about, this is from Philip Reed, and I'll just adapt it slightly. So what you think about using the point-of-care antibody test to start people on treatment, using the short duration to start people on treatment, and then maybe taking them off later on if you do an RNA test and you get that result, and then take them off later. And if so, I was just wondering, can you use that sort of test also for somebody who's been reinfected? Does it work for that?
Well, so the first thing I'll just highlight, at least in using the time to positivity that we were looking at, so it really doesn't work in the opposite direction. So it's good if the person's negative at 5 minutes, they're very likely not to be viremic. But if they're positive within 5 minutes, it's almost like flipping a coin. The positive predictive value is quite low, and that's because people can maintain antibody levels even after they've been cured. And some people, especially if they've been cured recently, then it really won't work for that. So I wouldn't use it to put someone on treatment. Now, there was a study done in New York where they said for people that were worried about losing, we're going to start them on treatment, and we'll get the RNA test, and we'll call them and tell them to stop if they don't need to continue treatment. I think that's an interesting model, but to be honest, in most places in the world, the drugs are so much more expensive than the cost of the test that doesn't make sense. In a setting like Pakistan, where the cost of the drugs is lower than the cost of the diagnostics, that's an interesting model, but I think it only makes sense when you've got really high loss to follow. And that really needs to be figured out in a context-specific way, and you're probably the person to tell us which is where and when to do that strategy.
Who has any? Do you have your second question?
Sure.
Go for it.
If there's time. My question's for Jordan. I think you made a really, really important point. As much as been doing a lot of stuff around point of care, I think that the reflex RNA testing point that you made is really critical, because that's a solution that we know increases sort of testing and in terms of RNA testing and confirmation of infection. Like in Australia, we've been able to roll out point of care RNA testing and scale that up, but we've actually had a lot of struggles getting the labs to take the reflex RNA testing on board centrally, like not the clinic-based. And I'm just sort of curious, in your experiences in Canada, like have you been able to convince people to get that? I think you have. And what was the arguments that you used to be able to get that up and running? Because you hear from the lab, there's two barriers. One's at the clinician level. They need to be trained to be able to order that second test. That's one thing. And then if not, then you put it on the lab's burden, make sure that they have a system in place that if it's an antibody positive test that they RNA tested, but then that requires 2 tubes of blood to be collected on every person, or like BCCDC in British Columbia, you do both tests off the single sample, but then there's concerns about contamination and dipping and stuff like that. So what did you use as your argument? Because we're working on that right now, and we're trying to get that going, but I'm sure other countries are struggling. UK's done it well, Spain, US, and yeah.
That's a good question. I mean, I don't think there's any magic answer. I mean, our experience was being the squeaky wheel. We just kept bugging them and saying, this is a good idea, this is a good idea, there's data for this, there's data for this, we should be doing this. And then I think, as with everything, it's doing it in a collaborative, thoughtful way. So we kept saying to them, let's do it together. So we provided samples to allow the public health lab to do their own validation studies so that they developed confidence in their process, so that they weren't we did talk to them about saying, look, this has been adopted in other places. It was helpful when it was adopted in the US by large commercial labs where in a very litigious environment, so they want to be very careful. That helped. But then we did work with them and say, let's go through the validation process that's going to make you comfortable. And at least in Ontario, the province where I live and work, we then worked with them to come to a sort of an acceptable route for them to do it. And I do think it was important because at the end of the day, the lab people own that decision, not the clinicians. And I think they want, it's their domain. They didn't want us to sort of take that from them, and I think that part of it probably is important anywhere.
Go for it, last comment.
Yep.
May I ask a question? As sitting here, Jordan, can I just ask you to revisit your view on core antigen? Because in a high-risk population, it's not point of care, I appreciate that, but reflex RNA still has to go to the lab. In a high-risk population, what's your view on core antigen?
I think core antigen is great. I think the problems with core antigen are two things. One is that it has to go to the lab and it's going to be hard to make it point of care. And two, and I guess with it going to the lab, it's using either the Abbott Architect or one of the other large machines, which not every lab has. So they have to have the lab and have the kits and have access to it. And then the sensitivity is a little bit of a challenge because especially for diagnosing reinfection or acute infection where HCV RNA levels fluctuate quite a bit, you do end up with, and as I showed you, the people that tend to have low viral loads are groups where you really don't want to miss them. So you can work it out, and I think it does depend on the prevalence of viremia and the population where you do either an antibody screen or you, in people who are antibody positive, go straight to core antigen, and then if it's negative, so if it's positive, you're good to go. The specificity is excellent. If it's negative, it depends, but you're going to still have, you're either going to have to accept that you have a miss rate, or you're going to have to do RNA testing on all those negative people, and that becomes a bigger problem over time because as you get to elimination, the number of people who are antibody positive, RNA negative goes up. And so you end up having to do almost as many RNA tests over time as you sort of approach elimination. So I don't think it's useless. I think it has a place, but I would like to see a more sensitive test. I don't think we'll ever see, at least not ever, I shouldn't say ever, but in the short term, we're not going to see a point of care test, but we could see a more sensitive core antigen test, and with that, then I think it really provides a good option.
Thank you. Thank you. I just want to say, should we say we? We would like to say thank you very much to everybody. If you've got any more questions, I'm sure you guys are, I don't know if you're running off or something. I want to say thank you very much to everybody who's been here today. Fantastic presentations, brilliant. And I guess there's a conference dinner later. If you've forgotten, you need a ticket. I think it's on a boat, am I right? It's on a boat at 6:30, but thank you very much from me.
Yeah, thank you very much.